Okay, so amenorrhea, it's one of those classic clinical challenges, right? It shows up all the time, but the list of possible causes is huge. The absolute key is having a solid, systematic approach you can rely on. So let's build that framework together.
All right, picture this. A patient walks in. She's 22, seems perfectly healthy, but tells you she hasn't had a period in 6 months. Where do you even start? This is exactly why a step-by-step method isn't just nice to have, it's essential to get to the right answer efficiently.
So here's our game plan. We're going to start with how a normal cycle should work. Then we'll define what's happening when it stops. From there, we'll build out a list of possible causes, walk through the actual workup step by step, and finally, touch on how to manage the most common conditions you'll find. Right, before we can figure out what's wrong, we've got to know what right looks like. And the normal menstrual cycle, it's really like a masterpiece of hormonal coordination, a perfect symphony. Think of the whole thing as this perfectly timed conversation between the brain and the ovaries. The brain sends out two key signals, FSH and LH. Early on in the follicular phase, FSH tells the ovaries to grow follicles, which then produce estriol. Then, bam, a huge surge of LH triggers ovulation. After that, we're in the luteal phase, and progesterone takes over to get the uterine lining ready. It's this beautiful, predictable hormonal dance that leads to a regular period.
Okay, so what happens when that beautiful symphony just stops playing? Well, that's what we call amenorrhea. But it's not quite that simple, because there are different types.
So the very first fork in the road is figuring out, are we dealing with primary or secondary amenorrhea? Basically, has this person never had a period? That's primary. Or did she used to have periods and now they've stopped? That's secondary. This distinction is crucial because it points us toward very different sets of potential causes.
And this is a huge number to remember, especially for primary amenorrhea. A full 50% of cases are due to genetic abnormalities. The one we see most often is Turner syndrome. And that's exactly why ordering a karyotype can be such a critical piece of the puzzle for these patients.
Okay, so we've defined the problem. Now let's start playing detective and build our list of suspects. And the best way to do that is to think about where along that brain to ovary pathway things could have gone wrong. The easiest way to think about this is to break it down into four main locations where the problem could be. Is it a signaling issue from the brain, either the hypothalamus or the pituitary? Or is the problem with the ovary itself? Or maybe it's a structural issue, something wrong with the uterus or the outflow tract. For example, functional hypothalamic amenorrhea, FHA, is a brain problem. Primary ovarian insufficiency, or POI, is an ovary problem. Same with PCOS. And here's a really important one to keep in your back pocket. After pregnancy, of course, the most common culprit for secondary amenorrhea is something called functional hypothalamic amenorrhea, or FHA for short. This is when the brain basically decides there's too much stress from things like major weight loss, intense exercise, or even high psychological stress, and it just shuts down the reproductive signals to conserve energy. All right, this is the real meat and potatoes of it all. We've got our list of possibilities organized by location. Now, how do we actually investigate and figure out what's going on with our patient? First things first, you absolutely cannot skip the basics. A great history can give you so many clues. Ask about stress, diet, exercise, family history. The physical exam is key for looking for things like signs of high androgens or low estrogen. And then, before you do anything else, you get a pregnancy test. It's the most common cause, so always rule it out first. Only then do you move on to blood work. And here they are, the big four labs you're going to order: FSH, TSH with free T4, and prolactin. This is your initial panel. These tests are incredibly powerful, and they are going to point you in the right direction almost every single time. Okay, labs are back. Now what? Your first move is to look at two specific results, TSH and prolactin. The reason we look at these first is because if either of them is off, it points to a very specific and often very treatable problem. And if one of those is high, your path is pretty clear-cut. An abnormal TSH means you're headed down a thyroid workup. If the prolactin is elevated, you'll want to repeat it to confirm, double-check the patient's medication list, and if it's still high, you're likely thinking about getting an MRI of the pituitary. All right, let's say your TSH and prolactin come back totally normal. We've checked off those boxes. Now, we turn our attention to the FSH. This is the test that's going to help us figure out if the problem is at the level of the ovary or if it's a signaling issue coming from the brain. So here's how to think about it. A high FSH is like the brain yelling at the ovary, but the ovary isn't listening.
That points to a problem in the ovary, ovarian insufficiency. But if the FSH is normal or even low, it means the brain isn't sending the signal properly. In that case, the next logical question is, well, is the ovary still making any estrogen on its own?
And how do we figure that out? We do something called a progestin challenge test. We give the patient a short course of progestin and then stop. If she has a withdrawal bleed, it proves two things. One, her body has enough estrogen to build up a uterine lining, and two, her anatomy is normal. The outflow tract is open. A positive test here often makes us think about conditions like PCOS.
Okay, we've gone all the way from the patient walking in the door, through our differential, and down the diagnostic algorithm to a diagnosis. Now let's talk about what we actually do about it. And what's really elegant is that the management strategy directly targets the core problem we just uncovered. For FHA, it's all about restoring that energy balance with nutrition and maybe cutting back on exercise. For POI, it's about replacing those hormones for things like bone health and providing support. High prolactin? We have meds to bring it down. And with PCOS, we're focused on managing symptoms and thinking about long-term metabolic health. So to wrap this all up, I want to leave you with a question to really lock this in. The next time a patient with amenorrhea is on your schedule, what are the first 3 questions you're going to ask yourself? Is she pregnant? Is this primary or secondary? And what does her story, her history suggest? By starting there, you'll be well on your way to navigating this common problem with a ton of confidence.